Welcome to this educational video on nonsteroidal anti-inflammatory drugs, commonly known as NSAIDs. In this presentation, we will cover the mechanisms of action, key drug classes, clinical indications, and the three major toxicity profiles, gastrointestinal, cardiovascular, and renal, that every clinician must understand. NSAIDs are among the most widely prescribed and used medications in the world, and their ubiquity makes knowledge of both their benefits and risks absolutely essential for clinical practice. This video is for educational purposes only and does not constitute medical advice. All patients should consult with their healthcare providers about any health concerns. Always refer to current clinical guidelines and institutional protocols when making treatment decisions. Let's begin with an overview of NSAIDs and their clinical importance. NSAIDs are a class of drugs with anti-inflammatory, analgesic, and antipyretic properties. They work by inhibiting cyclooxygenase enzymes, which are critical for prostaglandin synthesis. These drugs are the most widely used analgesics worldwide, with over 111 million prescriptions written per year in the United States alone, and many more available over the counter. However, this widespread use comes at a significant cost. NSAID-related gastrointestinal bleeding accounts for 60 to 120,000 hospital admissions annually in the ultrasound, and deaths related to NSAID toxicity may reach 16,000 per year. 15 to 30% of individuals taking NSAIDs regularly develop endoscopy-documented peptic ulcers, and critically, over 80% of patients with serious NSAID-related GI complications had no preceding dyspeptic symptoms, meaning the first sign of trouble can be a life-threatening bleed. Now let's examine the mechanism of action. NSAIDs work by inhibiting cyclooxygenase, or COX, which exists in two main isoforms. COX-1 is a constitutive or housekeeping enzyme expressed in virtually all tissues. In the stomach, COX-1 produces protective prostaglandins, primarily PGE2, that maintain mucosal integrity by stimulating mucus secretion, bicarbonate production, and mucosal blood flow. In platelets, COX-1 generates thromboxane 2, which promotes platelet aggregation. In the kidneys, COX-1 maintains afferent arteriolar vasodilation, preserving renal blood flow and glomerular filtration rate. Therefore, inhibiting COX-1 leads to the classic NSAID side effects: GI ulceration, bleeding, and renal dysfunction. In contrast, COX-2 is an inducible enzyme upregulated at sites of inflammation by macrophages, leukocytes, fibroblasts, and synovial cells. Inhibiting COX-2 produces the desired anti-inflammatory, analgesic, and antipyretic effects. However, COX-2 is also expressed in endothelial cells where it produces prostacyclin, or PGI2, a potent vasodilator and inhibitor of platelet aggregation. This is why COX-2 inhibition can paradoxically increase cardiovascular risk. Let's now review the major traditional, non-selective NSAIDs. Aspirin is uniquely important because it irreversibly acetylates platelet COX-1, permanently inhibiting thromboxane 2 production for the entire 8-day lifespan of the platelet. This is why low-dose aspirin at 81 mg daily is used for cardiovascular secondary prevention, producing a 25% reduction in cardiovascular events. No other NSAID provides this cardioprotective effect. Ibuprofen, dosed at 400 to 800 mg every 4 to 6 hours, has the lowest GI risk among non-selective NSAIDs and is a good first-line choice for mild to moderate pain. However, an important interaction to know: ibuprofen can block aspirin's access to the COX-1 binding site, potentially negating aspirin's antiplatelet benefit. Naproxen, dosed at 250 to 500 mg every 12 hours, has the lowest cardiovascular risk of any NSAID due to its longer half-life providing more sustained COX-1 inhibition, though it carries higher GI risk than ibuprofen. Indomethacin is the most potent anti-inflammatory NSAID and is the classic first-line agent for acute gout, but it has the highest rate of GI side effects. It is also used intravenously for patent ductus arteriosus closure in neonates. Ketorolac is the parenteral NSAID of choice, given intramuscularly or intravenously for acute severe pain. It is potent enough to replace opioids for headache and musculoskeletal pain, but must be limited to 5 days due to significant GI and renal toxicity risk. Diclofenac is notable because it carries the highest cardiovascular risk among traditional NSAIDs, comparable to selective COX-2 inhibitors, though a topical formulation is available with lower systemic absorption and reduced risk. Now let's discuss the selective COX-2 inhibitors, also called COXIBs. Celecoxib is the only selective COX-2 inhibitor that remains on the market. It is 100 times more selective for COX-2 than traditional NSAIDs, which means its GI mucosal injury is comparable to placebo. The landmark precision trial, published in the New England Journal of Medicine in 2016, randomized over 24,000 patients with arthritis and elevated cardiovascular risk to Celecoxib, Ibuprofen, or naproxen. The results showed Celecoxib was non-inferior for cardiovascular safety, with a 2.3% rate of primary cardiovascular events compared to 2.5% for naproxen and 2.7% for ibuprofen. Celecoxib also demonstrated lower GI events than both comparators. An important clinical detail: low-dose Celecoxib at 200 mg per day or less has not been associated with elevated cardiovascular risk. However, two other COX-2 inhibitors were withdrawn from the market: rofecoxib in 2004 after the approved trial demonstrated increased myocardial infarction risk, and valdecoxib in 2005 due to increased cardiovascular events and severe skin reactions, including Stevens-Johnson syndrome. Let's review the clinical indications for NSAIDs. The primary uses include mild to moderate pain from headache, musculoskeletal, and dental sources, as well as chronic inflammatory conditions like osteoarthritis and rheumatoid arthritis. For acute gout flares, indomethacin and naproxen are classic first-line options, with high-dose Celecoxib as an alternative. Importantly, aspirin should be avoided in acute gout because it alters urate excretion. All NSAIDs have antipyretic effects through inhibition of hypothalamic COX and PGE2, with ibuprofen being preferred in children. However, aspirin must be avoided in children due to the risk of Ray's syndrome. For cardiovascular prevention, only low-dose aspirin is indicated, working through irreversible COX-1 inhibition to reduce thromboxane A2-mediated platelet aggregation. No other NSAID provides cardiovascular protection. Additional indications include patent ductus arteriosus closure in neonates using indomethacin or ibuprofen IV, migraine treatment combining naproxen with triptans, pericarditis, and ankylosing spondylitis. Now let's turn to the most common adverse effect: gastrointestinal toxicity. The mechanism involves COX-1 inhibition leading to decreased protective PGE2, which reduces gastric mucus, bicarbonate secretion, and mucosal blood flow. The spectrum ranges from nausea and dyspepsia, occurring in 50 to 60% of patients, through erosions and ulcers in 15 to 30% of regular users, to bleeding and perforation in 1.5% per year. A critical teaching point: no dose of NSAID is completely safe. Even 75 mg of aspirin can cause GI ulceration. Risk factors include advanced age over 65, history of peptic ulcer disease, concomitant anticoagulants or clopidogrel, glucocorticoids, high dose or multiple NSAIDs, H. pylori infection, and serious systemic disease. GI protection strategies include proton pump inhibitor co-therapy as first-line prevention, misoprostol at 200 micrograms 4 times daily, which is effective but limited by diarrhea and is contraindicated in pregnancy as an abortifacient. Switching to Celecoxib, which is GI injury comparable to placebo though the benefit is negated with concurrent aspirin, and using topical NSAID formulations like diclofenac gel for reduced systemic absorption. Next, cardiovascular toxicity. The mechanism involves COX-2 inhibition reducing prostacyclin production in endothelial cells, which eliminates its vasodilatory and platelet inhibitory effects. This creates an unopposed prothrombotic state with thromboxane A2-mediated platelet aggregation and vasoconstriction, increasing the risk of myocardial infarction, stroke, and heart failure. Additionally, sodium retention from prostaglandin inhibition leads to volume expansion and blood pressure elevation. Among individual agents, naproxen has the lowest cardiovascular risk. Ibuprofen and Celecoxib carry moderate risk as demonstrated in the precision trial, and diclofenac has the highest cardiovascular risk, comparable to withdrawn COX-2 inhibitors. The FDA issued a black box warning in 2015 stating that all NSAIDs except aspirin increase the risk of serious cardiovascular thrombotic events, myocardial infarction, and stroke, and that this risk may increase with duration of use. Importantly, cardiovascular risk exists even with short-term use, potentially within the first 7 days of therapy. Renal toxicity represents the third major adverse effect of NSAIDs. The mechanism involves prostaglandin inhibition causing afferent arteriolar vasoconstriction, which reduces renal blood flow and glomerular filtration rate, leading to parenteral azotemia. NSAIDs also cause sodium and water retention resulting in edema, hypertension, and heart failure exacerbation, and they reduce renin secretion leading to hyperkalemia. A distinct entity is NSAID-induced acute interstitial nephritis, which has an atypical presentation compared to other drug-induced AIN. Patients often lack the classic triad of fever, rash, and eosinophilia, but present with acute kidney injury and heavy proteinuria. The critically important concept is the triple whammy. The combination of an NSAID plus an ACE inhibitor or a ARB plus a diuretic increases the risk of acute kidney injury by approximately 30%. The NSAID blocks afferent arteriolar vasodilation, the ACE inhibitor blocks afferent arteriolar vasoconstriction, and the diuretic causes volume depletion. Together, these three mechanisms converge to collapse the kidney's ability to maintain adequate glomerular filtration. High-risk populations include patients with volume depletion or on diuretics, CKD stage 3 through 5 where NSAIDs are contraindicated, heart failure, and the elderly. Understanding drug interactions in special populations is crucial for safe NSAID prescribing. Key drug interactions include increased bleeding risk with warfarin and direct oral anticoagulants, reduced antihypertensive effect and increased AKI risk with ACE inhibitors and ARBs, increased lithium levels leading to toxicity through decreased renal clearance, increased methotrexate levels through decreased renal tubular secretion potentially causing pancytopenia, and increased GI bleeding risk with SSRIs which also inhibit platelet function. The aspirin-ibuprofen interaction deserves special emphasis. Ibuprofen can competitively block aspirin's access to the COX-1 active site on platelets, negating its cardioprotective antiplatelet effect. For special populations, NSAIDs should be avoided after 20 weeks of pregnancy due to risk of oligohydramnios and premature ductus arteriosus closure. Children should never receive aspirin due to Reye syndrome risk, though ibuprofen is safe. In the elderly, NSAID prescriptions are considered inappropriate in approximately 50% of patients over 65. A high-yield USMLE concept is aspirin-exacerbated respiratory disease, also known as Samter's triad, the combination of asthma, nasal polyps, and aspirin or NSAID sensitivity, affecting 5 to 10% of asthmatics. COX-1 inhibition shunts arachidonic acid metabolism toward the leukotriene pathway, causing bronchospasm. These patients should avoid all COX-1 inhibitors but can safely use COX-2 inhibitors and acetaminophen. Treatment includes leukotriene modifiers like montelukast. Let's summarize the key high-yield points about NSAIDs. The mechanism involves inhibition of cyclooxygenase enzymes, with COX-1 as the housekeeping isoform responsible for GI protection, renal blood flow, and platelet function, and COX-2 as the inducible isoform mediating inflammation. Aspirin is unique in its irreversible inhibition. Key traditional NSAIDs include ibuprofen with the lowest GI risk, naproxen with the lowest cardiovascular risk, indomethacin as the most potent anti-inflammatory for gout, ketorolac as the parenteral option, and diclofenac which carries the highest cardiovascular risk. Celecoxib is the sole remaining selective COX-2 inhibitor. The three major toxicity patterns are GI toxicity from COX-1 inhibition prevented by PP or misoprostol, cardiovascular toxicity from COX-2 inhibition creating prothrombotic imbalance, and renal toxicity from prostaglandin-dependent vasoconstriction with the triple whammy as the highest risk scenario. Remember the teaching, mnemonic, /numbing/, NSAIDs gut the stomach, squeeze the kidneys, and clot the heart. The information in this presentation is based on Harrison's Principles of Internal Medicine, 22nd edition, and peer-reviewed clinical literature including the Precision Trial and the CNT Collaboration meta-analysis. All references are listed on this slide with their full citations and PubMed identifiers for your review. Thank you for watching this educational video on NSAIDs. Remember to always consult current guidelines and use evidence-based practice when prescribing these commonly used medications.